So what this is, and we're going to emphasize a little bit about the central part of this, the screening, brief intervention, and referral to treatment. And we're going to go into something called the brief negotiated interview. Learning objectives to really understand, the order and flow of expert practices. There's a little flow chart and a decision tree that we'll be looking at. The purpose of brief negotiated interview, where it's not necessarily treatment. We're not trying to get somebody to arrive at you know, a profound insight and a flight into health, in as much as them start to maybe question some of their behaviors, and let those questions, kind of leave with them where they're going to continue to think about this. And then if there's a lot of slides on here for motivational interviewing, because I really launch into motivational interviewing. And the other day, rather than just jettison all of those MI slides, I left those slides on here, so you might be able to use those as a primer for MI after this is down, because you could download these PowerPoints. So first thing is when we get into this, most people in the United States that need or can use or benefit from SUD treatment don't get it. In 2022, there's about 320 million people in the United States. 50 million of them are estimated to have some type of substance use disorder. Of that 54 million, only 26%. So we're looking at what, maybe about 13 or so. 13% of that 54 million of this group has received any help. So a lot of the people that need it don't get treatment for it. Then of those 40 million people in a similar report who needed but didn't receive that treatment, only a small portion of them thought they needed it. So the vast majority of people that have substance use disorders in the United States really don't think they have a problem. And for people working in the field, it's kind of common for people to enter treatment through the court system or some other mandated service, that once they get to treatment, they really don't think they have a problem. And there's a lot of strategies, including motivational interviewing and stages of change model and stage-wise therapy, that we can work with that resistance. But to always wait for somebody to desire treatment isn't really necessary all the time. There's ways that we can, there's an old saying, you could bring the horse to water, but you can't make him drink. But you can make the horse thirsty once he gets to the water. And that's what we're going to go a little bit here. So the question is, a lot of people that enter substance use treatment are mandated. In Ohio, about 70% of people that are going into publicly run drug and alcohol treatment programs or SUD treatment programs are mandated. It's either by the courts, it's by children's services, it might be from, public housing. But there's usually some parallel universe that's sanctioning them into treatment. So a lot of the people, it's really, until they get caught, there's no incentive or there's no efforts to try to get them into treatment. So the question is, everybody uses healthcare. Whether you're indigent, whether you're well-insured, whether you are going in for wellness checks, whether you're going into an emergency room, everybody at some point uses the healthcare system. So the question is, what if persons were screened for substance use disorders or behavioral health issues whenever they had a healthcare encounter? And it's just one of those public health models of, can we open the door wider? Can we leverage that interaction that almost everybody will have with the healthcare system to do some screening for some things that can really benefit and impact their quality of life. Now, SBIRT, it's an evidence-based model. Now, there's been some pushback for it. And some of the pushback originally is, again, can we do screening and brief interventions and referral to treatment in a standard physician's visit? And when this was first being discussed, and I know Dr. Ellis might have a little bit more information on this, there was some pushback by some medical groups of, we really don't have the time to be able to introduce something like this. A typical, face-to-face visit in primary medicine is sometimes about 15 minutes. And that 15 minutes is chock full of the medical discussion that needs to take place, or the medical agenda that is to address the presenting problem. So where do you fit this additional service? In an emergency room, there's walking back and forth to different patient spaces. Where is the space to be able to have these dialogues? So when this was developed, the SBIRT was developed to only be it could be anywhere from 3 to 10 minutes in some scenarios. So they really did this in a brief way, and it's designed in a way that it could be naturally embedded in a physician or a different kind of health encounter with a nurse practitioner, a social worker, anybody that works in a healthcare system, to have these brief dialogues and screenings for substance use. Now, the core components are screening, and that's just we assess. The brief intervention is, and what I'm going to talk about is the brief negotiated interview. It says additional sessions of brief intervention emphasizing motivation to change and clients' empowerment may be provided to moderate or high-risk users. So this would almost be a pre-treatment model. But the brief intervention can just be a 2-minute dialogue embedded into that interaction of an emergency room nurse practitioner or a primary care physician when they meet with the client, just to bring up the conversation, bring forward some questions about that particular behavior, and ask if they would like some help with it. And then referral to treatment, providing a referral to some kind of brief therapy or other additional treatment for people that screen positive. And we're going to take a little closer look at what these referrals mean. I know this isn't something you're going to hear about in literature, but I'm from my experience, I'm not a fan of the catch and release models, where we just give somebody a piece of paper and here's the referrals and follow up. So we're going to get a little bit more into how we can make these referrals something that's a little bit more patient-centered. Now, when we get into the flow, up here we have the screening instruments. There is a number of validated screening instruments, the audit, the craft, the NIDA quick screen that I'm going to be going over here. There's also some screenings that aren't based on an instrument. That could be a particular kind of lab report that you got back. Something that as simple as alcohol on someone's breath at 9 o'clock in the morning in an emergency room. So there could be some screenings that are these standardized type of screening instruments, and there can be some that is just your medical or behavioral health observation of a particular client. So if someone screens positive, if there's a positive screen, you just do a brief assessment. Is there an overdose risk? Is there a withdrawal risk? Is there a prescription interaction dynamic that we need to be aware of? Just off the top of your head, how severe is this? And if there's really little concern there, just some low-level, brief motivational interviewing, and maybe an idea is if you ever thought this was a problem, here might be some resources for you. If there's some moderate concerns with some of those issues, it would be the brief motivational interviewing with a referral. So we're not stopping, we're not involuntarily committing, we're not doing any of that. It's really just a brief conversation and a referral. That could be an informal, that could be formal. Now, if someone is screened and their screening is negative, we just want to reinforce good choices. Now, there are some practices in some healthcare settings that do screenings routinely on different months of the year, say. So if you're running a family practice, that maybe in April is Alcohol Awareness Month, that there might be a lobby instrument that everybody that comes into the lobby during that month gets a night of quick screen or gets an audit while they're sitting out in the lobby. And then once they get back into the physician space, that will enter the conversation that this is, Alcoholics Awareness or Alcohol Awareness Month. We're just doing screenings for everyone. And just go, and would you like to know what your scores represent? Would you like to know what your scores mean? And it's simple as that to just generate a conversation. And I know that there's one of the local healthcare networks that they do the same thing. They'll screen for domestic violence periodically. They will do a PHQ-9 for depression periodically. They'll do something like a GAD-7 for anxiety periodically, but it's the same thing. It's just a screening. And then once they get back in the space, this is what the screening instrument was. Would you like to know what your results mean? And go into it just like that. Now, the NIDA quick screen is something that it's so simple that you could place this into your memory without having any formal type of uh, having them fill out the tool. It's just in the past year, have you used any of the following? So in the past, and these examples of alcohol, 5 or more drinks in a day or 4 or more drinks in a day for a woman, that is considered uh, that's kind of standardized definition of a heavy drinker, 5 or more drinks in a day. So with this being the alcohol use disorder echo, I want to focus on that. But if anyone says there is a day a week, or at least one day a week, where they're having 5 or more drinks, that would be considered a positive screen. Now, this is just on the NIDA quick screen. Again, just what I said. If they say yes to 1 or more days of heavy drinking, this is somebody that would be considered positive and might be worthy of more conversation about this particular thing. It doesn't mean they're not going to be defensive about it. And many people might be. You're just offering, well, this is what it means. Do you have any thoughts about that? And bring up some type of brief dialogue surrounding this. So I'm going to get into another one. And this is something that without using a standardized tool or instrument for screening. So we have Joe Doe. And the reason I picked Joe instead of John is I believe, and I have a personal investment in this, John is overused in terms of John is used to describe consumers of prostitution. John is used to describe public bathrooms. John is used to describe dough quite a bit. So I'm trying to get a culture change here and remove John from the whole Doe family. So Joe Doe is a 27-year-old male that comes into the emergency department following a 1-car automobile accident. Minor injuries were sustained. He reports never really drinking more than 2 beers. So, and he seems sober. He doesn't seem under the influence outside of the minor alcohol breath type of smell. But his BAC came back as a 0.23. So here's somebody that's in the emergency room and they're sharing that they never have more than 1 or 2 beers. They blew a 0.23, which came back on either a breathalyzer or blood work. And I'm asking, the audience here, a lot of you are physicians or work steeply in behavioral health. What does that 0.23 mean to you? What does that 0.23 tell you? And would you launch into any kind of conversation about that disclosure of 1 to 2 beers versus that blood alcohol content? Any thoughts, anybody?
I think he's pulling my leg.
They may be really big beers that aren't standard beers.
There you go.
I never even thought of that. That's a good one. It's a real clever way for this young man to be able to maintain his honesty. But we're looking at a 0.23. Now, generally, if the state level for an OVI or operating vehicle under the influence is 0.08. And originally, it was at 0.15 in Ohio, then it went down to 0.10, and Ohio didn't want to go down to the 0.08, and the federal government threatened Ohio with, we will take away your federal highway dollars, and this was in, I think, the early 90s, if you don't go down to 0.08 like everybody else. So finally, Ohio complied. But if somebody has a 0.08 and they are slurring their words, they have a staggered gait, I would not be as concerned with them in the context of a substance use disorder than I would somebody with a 0.23 that doesn't have slurring words and doesn't have a staggered gait, because it introduces tolerance. The only way for somebody to be able to function well, and it takes some pretty fine motor skills to drive a car, when you really think about it, if you move the steering wheel 10 millimeters off center, that's a lane change at 60 miles an hour. So it really does take some pretty fine motor skills to drive a car. And if they're doing it well with a 0.23, it means they have a tolerance. And to get that kind of tolerance, they drink a lot. And some conversations could be as simple as, to let them know, I'm not the person that pulled you over. I'm a physician, or I'm a social worker, or I'm a nurse practitioner. I just want to get a handle medically on how much you're drinking, and maybe have a brief conversation about that. Because there are going to be people, especially in the emergency room, that are going to be very resistant to sharing full disclosures about what's going on. But is there any other lab findings besides a BAC that might trigger a conversation for you? Because I know we have some PCP here, some family medicine. What was that?
Kidney, liver damage, things like that.
So anything that you're seeing with liver, is there particular tests that would give you that insight?
GGT is probably the most sensitive.
And do you think that with those lab works in medicine throughout, we'll just say Ohio or in your area, do you think that when people have high screens on those, or really telling information that suggests severe alcohol use on those, that it's immediately followed by a conversation about that, or no?
Sometimes. The other lab test might be an elevated mean corpuscular volume. The red blood cells are big without necessarily being anemic. That's not totally specific, but again, suggestive of alcohol. A lot of the time you're thinking, okay, I don't want to go down that rabbit hole. But if you don't usually measure the GGT unless you're wondering a little bit. But I think a lot of times you'll just let that slide.
I would think triglycerides and sodium levels sometimes.
So there are some tests out there and some lab work out there. and maybe beginning at the med school experience to start tethering these to suspicion of certain potential for substance use disorders, and enter into conversations about these kind of things. Because it's a lot of times that might be the first conversation someone has had with this individual. Because if an individual hasn't yet gotten into legal trouble and they haven't yet gotten into children's services trouble, and if their romantic partner is somebody that's as heavy a user as they are, which is not rare, this might be the first real conversation someone has had with them about their substance use. And as a person in recovery myself, and who's traveled the halls of 12-step groups for about 39 years, I cannot count the times that I hear somebody in their story or their testimonial or their lead say that the first person that brought up their drinking to them was their physician. Not everybody goes through the courts. So the brief negotiated interview is the next step of this. And the BNI, it's just a way for healthcare providers primarily to really talk to clients or patients in a non-judgmental way in a very short period of time. Instead of telling people what they need to do, you need to quit drinking. You need to stop drinking. If you keep drinking, you're going to die. If you don't quit smoking, you're going to have an ugly death. Instead of the judgmental and true concerns that you have, it's how do we get them to think about this more and give them some reasons to change in a finite period of time. You know, this is just it's an ideal strategy for a brief encounter. You know, there's several models of this. There's even a brief negotiated interview institute that I have on one of these slides. Now, if you look at this later, there's two very brief, poorly acted vignettes of emergency room visits, one of how not to do a BNI and one to do how to do a BNI. So we want to save time for Dr. Block and his patients. So I'm not going to go over these videos, but they're amusing, I'll tell you that, if you do want to go back to these later. And just to share this, I teach a M4 class over at Neomed, and when I show these how not to do the BNI, I ask all of them, do you think there's physicians like that? And everyone said yes. And then we go into the how to do a brief negotiated interview. Now, Pennsylvania, they rolled out a model and this originally it was developed by their public health institute, and it was originally a training for ER staff or emergency department staff. And this card, and it was really given to them in a little, laminated about 4 by 6 inch card, the perfect size not to fit well in your wallet, is just some brief steps to begin with a general conversation. Ask permission to talk about their drug use. And sometimes a good way is to ask permission do you want to know what this particular lab results means from a medical perspective? And that's a good way to ask. Would you like to, can we talk for a moment about your drinking? And when we ask the question, there's some level of, we'll just say magic to it, that something about asking permission to talk about a topic, you almost always get somebody saying yes, but it involves them in a way, it gives them some power, and they're more willing to discuss. What are some pros and cons? And we're trying to build discrepancy here of what are some good things your drinking does for you? What are some bad things? What are some not so good things your drinking does for you? And we just want to bring up those two sides of things. We want to reflect. If you ever go to a motivational interviewing training, the skill everybody does really, really well is the open-ended questions. But according to the developers, somebody who's proficient at motivational interviewing has at least 2 reflections for each open-ended question. So it's those reflections that really get things deeper. To provide feedback, again, ask permission. Would you like to hear my thoughts on this? Would you like to hear, any insights that I have? Discuss the screening findings is a great way to do that, whether it's lab work or whether it's the lobby tool that they just completed earlier. Because if a patient does do one of those screening tools in the lobby awaiting you, they're curious. They would like to have that talked about. And just as a patient perspective, I remember doing one of those once, and I went back into the physician's office and it wasn't even mentioned. And I was curious. So provide feedback, and then we could build readiness to change. And this might be something as simple as smoking. Back in the mid 2000s, I'd guess about 2005, 2006, the state of Ohio, it was ODATIS at that point, created a rule where nobody could smoke inside any publicly funded residential or inpatient treatment centers anymore. And for those of you that are new to the field, yes, people were able to smoke in treatment. Sometimes people go back really far. People were allowed to smoke in hospitals. But one of the things that was brought up and added to the assessment was, instead of just asking if people smoke, do you smoke? How many packs a day or how many cigarettes a day? The question that was never asked after that in these history and physicals is, if they said yes, the next question should be, and is now, would you like help quitting? It doesn't mean they're going to, but we'd never asked before mid 2000s. We'll just say 2005, 2006. We just asked, did somebody smoke? We marked it down. Now we ask, do you smoke? Yes. While you're here, would you like help learning to quit? And it's amazing the responses we have or have had over that period of time. And if somebody is ready to quit, the readiness ruler is simply, how ready are you to make this change on a scale of 1 to 10? 0 meaning I'm not ready. I'm going to smoke a cigarette as soon as I get out of here. 10 being, oh my God, yes, absolutely, 100%. That's why I'm here. But if somebody says, how ready am I to quit smoking or quit drinking? I'd say about a 4. So it means low level of readiness. But your next question is, why not choose a lower number? Why a 4 and not a 2? And it puts them in a position to give themselves a positive, to really look at their making progress from 0. What can I do to help you get to an 8? You're not saying, what can I do to help you quit smoking right now? You're saying, what can I do to help you get more ready to quit smoking? And if you're a family practitioner, or you're a physician or a nurse practitioner that sees the same patients routinely, the next time they come back, how are you doing with that? How ready are you on the same scale now? And you might see that they're moving up. Now with the referral to treatment, okay, so somebody's positive. They screen positive, they're a heavy drinker once a week. Now what? So we've screened them. And okay, so do I just say, here, call these numbers? The general rule is, the more effort walls we place between them and a referral, the less likely they will follow up. So just giving them a couple phone numbers or suggesting they call Alcoholics Anonymous isn't really sufficient. A lot of these papers might not even leave the healthcare system that you're in. They might find the first garbage can on the way out. They might find them on the floor of their car 6 months later. Do we involuntarily commit them? Because they need help now. And in the state of Ohio, there is no involuntary commitment laws that extend to substance use disorders. Do we make them promise me, you will never drink again? And they might promise just to placate us or placate you, just like they have their family and friends maybe for a long time. It's an ineffective strategy, but it makes us feel better. And do we refer to their PCP? If they have one, certainly this should be placed into the chart or placed into their record somehow, that their primary care physician knows that there's a concern for substance use disorders. But some things to know about referrals is, what are the referral sources in your community? Are you referring them to a place that's even covered by their insurance? Is it close to them? Is there any nuances? Like in Summit County, there is treatment programs specific for minority populations. There's Urban Minority Behavioral Health Group. There is Urban Minority Alcohol and Drug Outreach Program. If you get into Lorain County, there is a Hispanic UMADOP. There is El Centro, which is a service that is Spanish speaking. There is Casa Alma up in Cleveland that is Spanish speaking. There is programs specific to the LGBTQ population. So what are the resources in your community? Do you know the nuances of 12-step meetings? Which meetings are open to a person on medication-assisted treatment? Which ones might be gender specific? If you have a patient that we'll just say is a woman, and you know that there is a profound sexual assault experience that she's had, to send her into the general population of 200 people in an open AA meeting and ask her to stand up and say she's new, in the context of that trauma, is not the best plan. So are there some gender specific meetings in your area? Are there some in the morning? What I would suggest for those of you that are in private practices, if you have a client or a patient that has been successful and they're on medication assisted treatment, or they are in the LGBTQ population, or they are some other minority, or have a trauma history, ask them, hey, is there some meetings that you would suggest, or is there meetings that you go to that are really accommodating of people on MAT? And find out where those are and jot that down someplace. Because even in the 12-step community, there's different factions of people that cluster together. And there's some meetings that may ostracize somebody on medication-assisted treatment, and there's some other meetings that will welcome them with open arms. So it's really up to us to find out which ones are which, so we don't send anybody into the lion's den on a well-intended referral. And again, the more effort walls we place, the less likely they are to follow up. So if we can make a warm handoff to any of these referrals, there's a greater likelihood that they would go. And if they don't, the next time they're in your office, just go in that readiness scale and, hey, can I ask if you followed up with that referral? And if they say, no, I didn't have time, it's like, okay, that's okay. Let's look at how ready you might be to make that change, and then go right into that readiness ruler again. Now, these are an easy and quick way to find behavioral health resources. This is a county map of Ohio. I'm sorry, I don't have something nationally here. But if you go to this link, you could click on any one of these counties, and you just click on it. It takes you right to the Adams board in that area. It'll take you right to their website, and they will have on the front page of their website, need help, local resources. So if I'm working in Cuyahoga County and I have somebody from St. Clairsville, Ohio, which is in Belmont County, I could click on that Belmont. It will give me the contact information for that Adams board down there. And I could sometimes even give them the phone to talk to whoever picks up with where the local resources are. Alcoholics Anonymous, this is a link to anywhere in the country to find a meeting. You just punch in a zip code and it will tell you meetings in that area, and it will list them. It'll even have little asterisks for, this is women's only, this is Spanish speaking, this is for deaf and hard of hearing, this is, and it'll give you a little idea of the type of focus that meeting might have, or the type of demographic it's trying to draw. And the same exact thing with Narcotics Anonymous. This is just for Ohio, but you push in a city, you push in a zip code, and it will give you meetings in that area. So bottom line is, this is a simple little model. We ask a question, we talk about it for about 2 minutes, and we make a referral if it's needed. And is it effective? Is something that simple effective? And, research indicates it's effective in reducing substance use in individuals those that are in a higher risk for negative social consequences. It will help reduce their use. However, it doesn't necessarily change their attitudes and beliefs towards people who use substances. So we have to work on the providers a little bit on here. There's still some judgment sometimes that providers might have, but the bottom line is the SBIRT model is very effective. So that's all I'm going to have. Like I said, when you download these slides, there's a number of other ones, including some short videos on having a brief negotiated interview. And now I just like to roll this into, we're going to save the questions to give Daniel some time. And now we're going to, Kara, can you queue up